This beautiful painting of the bathers by Renoir hangs in the Philadelphia Museum of Art, and every time I visit that city, I visit the painting. You might ask why it's in this article on idiopathic hypercalciuria. The answer is, as written here, bone always seems to me a bather in a bathtub. You can read the rest yourself. The alternative for this site would have been to use the Paul Cézanne large bathers. It's a much darker, more brooding image. But I wrote the original article in summertime, and therefore I chose the Renoir. What is idiopathic hypercalciuria starts with what is hypercalciuria, and it's a functional definition. Just like high blood pressure means a pressure associated with vascular disease, high urine calcium is a urine calcium excretion that associates with stones. This lovely work by Gary Curhan is a group of bars, the red ones women, the blue male. Cohorts are followed for years. Some became stone formers, others did not. The relative risk of being a stone former, or I should say becoming a stone former, is shown at the top of each of the bars. Along this axis are hexyles of urine calcium excretion in milligram per day. Clearly, the higher the calcium, the higher the risk. The bottom of each bar is the lower 95th percentile. At the point where the bottoms of all the bars are above 1, surely risk has increased. And that's the hexyl 200 to 249 milligram of calcium a day. So as a pragmatist, I say, the threshold for hypercalciuria defined by stone risk is 200 milligram a day. What do we mean by idiopathic? We simply mean that none of the many diseases that can raise urine calcium excretion is present. That's all. These are two bands of data, women and men, red and blue, are made of multiple tiny dots, one for each individual person, in whom a 24-hour urine was collected under what might call ideal circumstances during the course of research. I collected these points by combing through published papers from 1900 to about 8 or 10 years ago. This is urine calcium in milligram per 24 hour. It's the fraction of data encompassed. First of all, the men and the women are virtually the same. If you look at the medians, the 50% points, they're both around 150 milligram. If you look at 200 milligram per day, the beginning of risk, about 25% or so of perfectly normal men and women have values above that point, and yet only 7 to 10% of normal people form stones. So there's more to it than just calcium. Until not very long ago, we used to call high urine calcium, or hypercalciuria, the upper 95th percentile. This would be the value for women and the value for men, and here they're written out for you. The idea was, well, really high means very far above the average for normal people. There's nothing wrong with that criterion, it's just ridiculously too high for clinical use. We can use it for research. Now you might say, how does hypercalciuria cause stones? And it does it two ways. It raises supersaturation. You don't need to explicate that, or I don't need to explicate that for you. Higher calcium in the urine is going to raise supersaturation, and that's going to cause crystals. A lot of calcium stones form on plaque, and this would be a good time to click on the link and take a look. There's evidence that plaque is fostered by high urine calcium, and there's a plausible theory for that. So I would say hypercalciuria causes stones by supersaturation and perhaps promoting plaque. Hypercalciuria is familial and certainly hereditary. In this study of 9 probins, these are the arrows, where we measured urine calcium in their sisters, brothers, mothers, fathers, children. The hypercalciuric trait, which is the filled in female round, male square, is in successive generations, and about 50% of the blood relatives of a hypercalciuric stone former will have the trait. This would look like a simple Mendelian dominant trait, but it is not. It's clearly multigenic. David Bushinsky, a longtime colleague of mine, bred rats together who had the highest urine calcium excretions. This is generations of these genetic hypercalciuric stone-forming rats. This is urine calcium. As the generations went by, the urine calcium went up, gradually reaching a plateau by the 70th to 80th, maybe 90th generation. So it is a breedable trait in animals. As you would expect from a hereditary trait, hypercalciuria is present in children. In this study, the stone-forming siblings of calcium stone-forming children were studied for urine calcium excretion, along with a group of children that lived in the same neighborhoods but had no stones, nor any relative with stones. The siblings with greater than 2 stones had a rather high urine calcium excretion, the median above 200 milligram a day. The siblings with 1 to 2 stones had a lesser elevation of urine calcium, with a median around 150. The children who had no stones but were siblings of stone formers were lower still, but lowest of all, the children who came from families with no stones. Here the bars show exactly the same thing, but without the details of the individual children. Normal children, siblings of calcium stone formers, 1 to 2 stone siblings, greater than 2 stone siblings. This is calcium excretion in liters per day, and they're normalized per body surface. The more stones, the higher the urine calcium. This is exactly how it would work if the genetic trait caused stones. Here in passing, I bring up the fact that hematuria from crystals can occur in hypercalciuric children. You can read it yourself. I'd like to now turn to the question of bone disease. This is epidemiological work from Rochester, Minnesota. These are people who ever had a kidney stone. This is cumulative incidence of fracture. This is the general population. It's over a period of 24 years, and the fracture in question is vertebral fracture. So having a stone is definitely associated with fracturing. In a very large review, the link is here, involving about 2,000 cases collected from 20 different studies, you can see the frequency or percentage of cases with reduced bone mineral density in the vertebral spine, the hip, and the radius. All areas are affected. Surprisingly, the radius is most affected, even though the vertebral spine was most affected with fractures. So there's no question that having stones can lead to fractures. Thiazide diuretics are known to be associated with a lower fracture rate, which would suggest the hypercalciuria is related to the fractures. I say this because thiazides lower urine calcium in hypercalciuria and could protect bone mineral. Whether or not epidemiologically hypercalciuria is directly associated with fractures remains, in my opinion, likely but unproven. This experiment asked if the level of urine calcium loss predicted future loss of bone mineral. Here's how we did it. We measured bone mineral density in groups of patients. We also measured 24-hour urine calcium excretion. 3 years later, we remeasured bone mineral density, and we calculated the change in bone mineral density at the femoral neck and in the spine over the 3 years. We plotted for each person the change versus the urine calcium as we measured it at the beginning. The 0 line means the bone mineral density didn't change. Plus means it went up, minus means it went down. These 68% containment ellipses tilt downward. In other words, the higher the urine calcium at the beginning, the greater the loss of bone mineral. This was true both in the femoral neck and in the spine. The higher the urine calcium loss, the larger the risk of losing bone mineral. Hypercalciuria is all about more calcium in the urine. So naturally we have to ask, where does the extra calcium come from? One place it could come from is the diet. These two graphs show the fraction of diet calcium absorbed for normal men and women, that's this orange line, and from hypercalciuric people, this is idiopathic hypercalciuria. The men and the women in both groups are the same, and so we have one line representing both. The median value for normal men and women is about 18% of the diet calcium is absorbed. For the hypercalciuric people, it's about 30%. So people with hypercalciuria absorb more calcium than normal. You can see negative calcium absorption. The reason for that is the salivary glands, the pancreas, the liver by the bile, and maybe the ileum secrete calcium from the blood back in the bowel lumen. So when diet calcium is really low, this so-called endogenous secretion can cause the GI tract to lose net calcium from the body. The whole business of increased absorption drove thinking about hypercalciuria for decades. You absorb a higher fraction of your diet calcium, the calcium comes into the blood, the kidneys lose it, done. This theory led to low calcium diet as a treatment for hypercalciuric stone disease for decades on end. No one knew that such diets might cause bone disease and fracture. It's fairly easy to show that the calcium can come from bone. In this experiment by Jack Lemmon, normal people, calcium stone formers, and their immediate blood relatives were given a glass of sugar beverage, sucrose or glucose. Control period before you gave them the sugar, this is the urine calcium of the normals. This is the baseline urine calcium of the stone formers, much higher. This is the relatives, all higher than the normals. You give them the sugar, the urine calcium goes up. You give it to the patients, goes up, but from a higher baseline. Goes up from a higher baseline. Everybody here is fasting. Most likely you're losing bone mineral extra, just sitting around. When you get the sugar, this impulse of extra calcium in the urine cannot come from food. It has nowhere to come from but bone. Separately, not in this experiment, Jack Lemmon proved that the kidneys themselves lose the calcium when you feed them sugar. They fail to reclaim it into the blood and let it go out of bone, out of the body, into the urine. In this experiment, I got 9 normal people to eat a very low calcium diet, about 2 milligrams per kilogram body weight per day. That's about 140 milligrams of calcium. During days 1 through 7, they ate the diet, and days 7, 8, 9, they continued the diet, and we collected 3 24-hour urines shown as dots. They ate the diet very well. Their urine calcium generally was 2 milligrams per kilogram per day or less, and the arithmetic difference between what they swallowed and what's in the urine was positive. In other words, they ate more calcium than was in the urine. We did the same with this large group of patients. They ate the same as the normals, but look at the difference between what they swallowed and what appeared in the urine. There's calcium in the urine they didn't eat. Everybody was in negative calcium balance at this low a calcium intake. The normals could only absorb 18-20% of what they were eating. So therefore they were negative. But the patients were vastly more negative, and many of them, even if we assume they absorbed 100% of the calcium they swallowed, they're losing bone mineral in the urine. So it's very easy to show that the urine calcium can come from bone in hypercalciuria. This is the sum of the calcium balance experiments from the 100 years worth of journals I poured through to collect these data. On the y-axis is the 24-hour urine calcium collected in the special research units where this work was done. On the x-axis is the amount of calcium absorbed. That's the amount of calcium eaten minus the amount in the stool. Absolutely certain. This is the line of identity. These microdots in blue are normal men and women. These red dots are all patients with idiopathic hypercalciuria, mostly stone formers. If you get as high as 150 milligram a day of calcium absorption, let's draw this line up, the majority of your microdots are to the right of this line of identity. In other words, you're absorbing more calcium than you are losing in the urine. At that same level, the overwhelming majority of hypercalciuric people have more calcium in the urine that they absorb. As a matter of fact, to get hypercalciuric people so that a majority of their points are positive, you have to absorb 350, maybe 400 milligrams of calcium a day. It's almost impossible. So throughout the wide range of calcium absorption studied by all of these scientists over a century, hypercalciuric people are freely and flagrantly losing bone mineral in their urine on a day-by-day basis. The probable reason why reduced bone mineral density is so extraordinarily common in patients with calcium stone. An alternative and perhaps more dramatic way to say the same thing is this graph. On the y-axis is calcium retention. That's the actual difference between the calcium absorbed and the urine calcium lost. So this is bone calcium balance. I've plotted it here against diet calcium intake. The blue wiggly line tracks the normal people, the blue dots. By about 700 milligram or so, somewhere in here, the line passes through zero, which means the average person has achieved bone mineral neutrality. As the calcium intake keeps going up, a higher and higher percentage of blue points are above the line. These are adults, and so actually one would expect that in a population of adults, about half would be above, half would be below at any one time, under any one set of diet conditions, since bone mineral is at best not increasing. The hypercalciurics never really get, on average, into balance, even with very high calcium intakes. This is just another way of saying what the prior graph said. Idiopathic hypercalciuria involves a fairly easily demonstrated loss of bone mineral, a kind of lability, a kind of incapacity of the person to maintain their bone mineral stores. I'm now going to tell you how the kidneys bring about this lability. For those of you who are tired a little bit and would like a good stopping point, a moment to go get a Coke and just rest up, this is a good time. Come back in 5 or 10 minutes when you feel good and we'll go on. For those of you who don't need a break, here we go. The kidneys release excess calcium in the urine, and that's why bone mineral behaves that way. Remember that the kidneys filter calcium and sodium out of the blood, along with a lot of water. You can read this material here yourself, but basically, we filter about 150 liters a day of water which is full of small molecules like sodium and calcium. And for calcium, we reabsorb somewhere around 98 down to about 95%, leaving 2 to 5% in the urine. Normal people, it's 2%. The hypercalciurics, 4 to 5%. And I worked out the arithmetic here for you, which you can read on your own. This is the critical part. The proximal tubule is that part of the nephron right after the glomerular filter. It's actually physically the largest single mass of cells in the kidneys beside the glomeruli. And in those proximal tubules, the kidneys reabsorb a very large percent of the sodium, the water, and the calcium. Here's the key. In the proximal tubule, sodium and calcium are reabsorbed together, more or less 1-to-1. But if you look at the actual behavior of urine calcium excretion here in milligram per day as a function of urine sodium excretion in milliequivalent per day, you can see that patients with hypercalciuria don't have anywhere near the same behavior as normal people. This is the rate at which calcium goes up in the urine for a given amount of sodium. This is the rate at which calcium goes up over the same range of sodium in hypercalciuria. The proximal tubule couldn't do this. The sodium and the calcium come together. So on the one hand, the proximal tubule can deliver sodium and calcium downstream in the long nephrons that make up our kidneys. And somewhere downstream of the proximal tubule, calcium and sodium are separated. And in hypercalciuria, a higher percent is left to go out of the body. This is the fundamental characteristic of genetic hypercalciuria. You might say, why am I telling you this? Well, I'm telling you this because what we do to treat patients is lower diet sodium. And when you lower diet sodium, you most specifically decrease the rate at which the proximal tubule allows sodium and calcium to go downstream. Lower sodium will also reduce filtration a bit, and that will add to the effect. Thiazide diuretics, which are another common treatment to prevent stones and to lower urine calcium, work exactly the same way. They increase reclamation of calcium and of sodium in the proximal tubule. This gives you an understanding of why reducing diet sodium and taking thiazide are two ways of doing the same thing. I'm reading you the text now, almost. To the extent you limit your diet sodium, you don't need thiazide, because thiazide will simply act in the same place as the lower sodium diet. If you can lower your sodium and you need thiazide, it will be a lesser dose. On the other hand, if you take thiazide and need a lot of sodium, you'll undo the effect of the drug. And now I've told you why. Well, what about bone? When we eat, you lose calcium in the urine. And if your diet isn't providing enough calcium, then it's hard to understand how bone will be able to get calcium into itself from diet, and very easy to understand how bone will lose mineral into the urine. I showed you several examples of where hypercalciuric flagrantly lose mineral into the urine. So the ideal combination, in theory, will be a low sodium diet and a high calcium diet. That's the idea. This one experiment, a remarkable experiment in perimenopausal women, tested that. In the experiment, women ate one of 4 diets: calcium high, sodium high, sodium low, and so forth. This bar shows calcium absorption. This bar shows the secretion of calcium into the gut lumen by pancreas, bile, etc. And I've already spoken about that. This is urine calcium, and this is net bone calcium balance. A high calcium, high sodium diet, you can read the numbers in the text, Doesn't get you a positive bone calcium balance, but it is at least neutral or near neutral. A high calcium, low sodium diet, you decrease the secretion into the bowel lumen, you decrease the urine calcium, you now have bone mineral retention. Low calcium diets are hopeless. You never get positive bone balance. Before I leave this beautiful experiment, I want to call your attention to something. This is a 1200 milligram calcium diet. This is about a 500 milligram calcium diet. The urine calcium is exactly the same, even though calcium in the diet has gone up threefold. The secret is the low sodium diet. On that very same low calcium diet, if you lower the sodium even further, you hardly see a change anymore because diet sodium is so limiting. So when I say you can give people a high calcium diet and a low sodium diet, the urine calcium will be controlled. This is perfect proof of it. I offer here a theoretical idea about what makes calcium go in or out of bone when diet calcium is high or low and the kidney is losing calcium. I don't want to go over it in the video. For those of you who are interested, you can read it. I'm not sure if this theoretical idea is true or not. I don't know if it should be experimentally tested. I put it here, but I don't want to burden our current narrative. I want to close the video by talking about what we should do. I'm not going to read this to you. What I'm going to say is simply, we should do everything to reduce urine calcium. I've talked about reducing diet sodium. I showed you why reducing refined sugar is valuable. I didn't go over the protein effect, but the link does go over it. Protein loads raise urine calcium, and you want to be in the normal range of 0.8 to 1 gram per day. And all the decent stone testing vendors provide the protein catabolic rate, which gives you this number. For the bone, you have to provide the high calcium diet. If you do that with concomitant control of diet sodium, you will not raise the urine calcium, and you will potentially benefit bone given the trial I showed you. A small but important point: every stone patient has got a risk for reduced bone mineral density, and so you or some other doctor should order the test, get the test. If you're a patient, you should demand the test. You could read yourself about the insurance industry and their vagaries. The ultimate kidney stone diet is nothing more than reduced sodium, reduced sugar, adequate protein, adequate calcium. In addition, because of the kidney stone issue, you want to control diet oxalate. And I've pointed out in many other articles that the high calcium intake will reduce oxalate absorption, and you can click on the links and read about it. The diet is fundamentally healthy. It's good for hypertension, it's good for osteoporosis in principle, and most important, these recommendations accord with current U.S. recommendations for the entire American people. So I have no qualms about recommending these changes. In fact, I would say that on the one hand, I'd recommend them to my patients. I'd recommend it to the patients for their families, and I would recommend it to my family and to all my doctor friends too. Well, that's all I have to tell you. Thank you for being with me. I'm Fred Coe. Take care of yourselves. Bye-bye.